Hello, Dr. Gite, Hiren and Dr. Ganendra. Yeah,
Good evening, sir.
good evening. So our one of the student
Yes,
is
sir.
going to present today just a different surgeries for U junction obstruction. So you can guide him, and then we will present one last case, the third case scenario that we will discuss after that. Is it okay?
Yes, sir.
Yes, sir.
Okay. So
Yes, sir.
can we start it, or wait for 2-3 minutes and then start? Paras, once you are ready, please let us know.
Gite sir, Sharma sir are there. We can start, sir.
Once Paras is ready with his slides,
Yes, sir.
we
Yes, sir.
start. Okay.
Good evening, sir. Sharma sir, Gite sir.
Good evening, sir. Good evening, sir.
Good evening. Good evening, boss.
Sir, ready, sir.
You can start, Paras. Sir said already.
So, good evening, everyone. I am going to present different modalities of treatment for UPJO. So, what is UPJO? It is a significant impairment of urinary transport from venal pelvis to ureter, leading to impairment in the renal function. The main pathogenesis involved in UPJO are congenital UPJO, that is because of the aperistaltic segment or circular muscle which are replaced by longitudinal muscle. There is decreased interstitial cell of Kazar. So there is uh, a diminished peristalsis progression. There is excessive collagen deposit. There is exaggeration of congenital fold found in the ureter, or there may be a aberrant vessel. There can be external adhesion. There can be high insertion of ureter. There can be vesico-ureter reflux leading to kinking or tortuosity. It can be because of stone, post-op scarring, or upper urothelial carcinoma. So the option of intervention can be endourological or surgical. The endourological, it can be antegrade endopilotomy, retrograde endopilotomy, or a cautery wire balloon endopylotomy or endopyloplasty. It can be surgical, it can be in open form or a laparoscopic or a uh, robotic modality, or it can also be divided in under dismembered or non-dismembered pyeloplasty. So coming to the endourologic management, indication as so what are the indication for surgery in UPJO? If there are presence of symptoms of obstruction, if there is impairment of overall function, if there is a progressive impairment of ipsilateral function, development of stone or infection, or it is a cause of hypertension. Functional obstruction is defined as the progression of hydronephrosis or 10% reduction in the differential function on ultrasonography and a diuretic renogram. So these are the options for intervention. So coming to the endourologic management, the indication are already being told. The contraindication are active infection, untreated coagulopathy, or a more than 2 centimeter long segment of obstruction. The advantages of endourologic management are it is less morbid, reduce hospital stay, it is cost effective, it can be done in a frail patient or unfit for surgery. Disadvantages are slightly less success rate than open of laparoscopic surgical modalities. There can be complication like bleeding, urine leak, and hydropneumothorax. So coming to the antegrade endopylotomy, the prerequisite are we should always have a sterile urine culture before doing a procedure, and access across the UPGA should be well established. The technique is a glide wire is passed beyond the open end of the ureter catheter is placed, and RGP is done. A mid-posterior or a superior lateral calyx puncture is taken. A nephroscopy is done. A second safety guide wire is placed. A hook-shaped cold knife endopylotomy can be used. It is like this. It is a hook-shaped cold knife. Under the direct vision, the UPJ is incise and full thickness till the periureter fat and peripelvic fat is visible. This can be confirmed by doing a RGP, which will show the leakage of contrast region. Stent and Foley catheter is then placed. This is a cold knife endopylotome. Uh, uh, Endopilotomy can be done using retrograde approach also. The technique is similar. We will pass a glide wire beyond PUJ. Open and ureter catheter is placed. Flexible or a rigid URS will be used. Endopilotomy can be done using a 3 or 5 French cutting electrode, which is shown in the picture. It can be done using a laser. A stent and Foley catheter is then placed. This picture is showing endopilotomy retrogradely done using a flexible URS scope with a laser. The incision is made on the lateral surface as there is no vasculature there. There is another more modality, that is percutaneous endoplasty. It uses a special instrument of 5 mm suturing for suturing. It can be inserted through 26 French nephroscope. A 30 French implant sheet is positioned after percutaneous access. Convention endopilotomy is performed. You can see the stitching instrument in this picture. Nephros A nephrostomy is done, a nephroscope is placed in the picture. So we make it is just like a Hendrik Mikulicz procedure. We make a longitudinal incision and we close it transversely, and then we place a stent. Then cautery wire balloon endopilotomy under the fluoroscopic. It is marketed by the name of AccuSize catheter. Under the fluoroscopic guidance, AccuSize catheter is advanced over a glide wire up to UPJ. There is a balloon of 3 centimeter. The balloon is gently inflated with 0.5 ml dilute contrast to ensure that it is at the PUJ. The active wire is directed laterally and posteriorly as there is no vasculature there. The cutting wire is activated by 75 to 100 watt for about 5 seconds. Simultaneously, a 2 ml diluted contrast medium is instilled into the dilating balloon. As the balloon inflates, the stricture is incised. The balloon is kept inflated for 10 minutes as it causes tamponade and it causes stoppage of bleeding. Retrograde pylography is performed. It will confirm the dilatation by extravasation of at the site from the incision side, and then a DJ stent is placed. There is another technique called endobust balloon dilatation and rupture. A retrograde axis and a 24 to 30 French angioplasty balloon catheter is inserted and the balloon is inflated. But these techniques are now less frequently used as they have a very low success rate of around 30 to 40%. The most common complications in endourological approach are it can again lead to the stricture, it can lead to bleeding, it can lead to urine leak, stent migration, infection, ureteroarterial fistula, ureteric avulsion, or false passage. The for follow-up of these patients after the DJ removal, the first follow-up is at 1 month. We will do a history, physical examination, urine analysis, and diuretic renography. If normal, we will reevaluate the patient at 6 to 12 months. The most common recurrence occur within first 2 years. So patient should at least be followed for 2 years. The success rate of endourological procedure in the experienced hand is about 86 to 90%. In case of a crossing vessel, the success rate is reduced to about 42%. Now coming to the surgical repair, the primary principle of the surgical repair is to remove the diseased segment of the ureter. It should be funnel shaped, wide open, patent, dependent, tension free. It should have a mucosa to mucosa anastomosis, and the anastomosis should be watertight. Which are the conditions which require drainage before intervention? It can be either with a percutaneous nephrostomy or a DJ stenting. The condition are infection, azotemia due to bilateral obstruction or a solitary kidney, or unrelenting pain that is not reduced by medication. So the approaches for the surgical procedure can be open or laparoscopic or robotic. In open, you can go through flank approach or anterior extraperitoneal approach or posterior lumbotomy. For anterior extraperitoneal and posterior lumbotomy are done mostly in non-obese patients. They have direct access to the pelvic ureteric junction. For the laparoscopic approach, there can be a transperitoneal or a transport mesenteric modification of the transperitoneal or retroperitoneal. Most commonly used approach is transperitoneal. Mesenteric modification is used when the patient is thin build, so that there is less fat in the mesentery. The advantage is that it reduces the time of surgery and there is less bowel handling. Retroperitoneal approach is also used, but the spatial the retroperitoneum is less, so it can take a little more time and a more learning curve. So dismembered it can be divided into a dismembered pyeloplasty or a non-dismembered pyeloplasty. The dismembered pyeloplasty was promoted by Anderson Hines. It is almost universally applicable in all scenarios. Permit reduction of the redundant pelvis, straightening of the proximal ureter, complete excision of the abnormal UPJ. Even aberrant vessel can also be tackled. The only contraindications for Anderson Hines dismembered pyeloplasty is it cannot be done in case of a lengthy or a multiple proximal stricture or an inaccessible intrarenal pelvis. So this is a figure showing the Anderson Hines pyeloplasty. It is most commonly preferred by urologists. University same. If it is to be done in a bilateral scenario, then a transperitoneal approach can be taken. The recurrence rate is around 5%. So in this procedure, hello. So in this procedure, whether done from an open or a laparoscopic approach, we mobilize, we reach to the PUJ, we dissect around the PUJ, traction suture is placed on the medial and the lateral aspect of the dependent portion of the renal pelvis. The traction suture is also placed in the lateral aspect of the proximal ureter, which act as a marker for the lateral side, so that we may be properly oriented during the suturing. The uretero-pelvic junction is excised. The proximal ureter is spatulated at the lateral end, as there are no vasculature there. The apex of this lateral spatulated end of the ureter is then brought to the inferior border of the pelvis, and the medial side of the ureter is brought to the superior edge of the pelvis. So this you can see the lateral border attached to the inferior border, and the medial border is attached to the superior border. The anastomosis is then performed with interrupted or a running absorbable suture in the full thickness in a watertight fashion. In general, we prefer a DJ stenting, which can be done retrogradely before the surgery, or it can be done antegradely as per the surgeon choice. So in case of the redundant pelvis, in the dismembered pyeloplasty, we can cut out the redundant pelvis and we will excise the redundant pelvis. The cephalad aspect of the pelvis is then closed with running suture, brought down to the dependent portion, and the dependent aspect is then anastomosed to the spatulated ureter. The figure in the lower side, we can see aberrant vessel, which is causing the kinking of the kinking at the UPJO, causing symptom. So we perform the similar dismembered pyeloplasty. So Foley YV pyeloplasty, this is done in case of high insertion of bladder. Base of V is positioned at the dependent and the medial aspect of the renal pelvis. You can see in the figure, we make the incision at the dependent. So this is the incision side. The incision is taken up to the apex till the UPJO. The incision represent, and then the stem of the Y is carried around the lateral border of the ureter. The apex of, then a flap is created. The apex of this flap is sutured to the inferior aspect of the urethrotomy incision. The posterior and the anterior wall are then sutured. Antegrade DJ stenting or a retrograde DJ stenting can be done. In all these processes, dismembered pyeloplasty can also be done. Now, in case of a long segment proximal ureteric obstruction, there is a procedure for curved devert spiral flap. Spiral flap is outlined with the base of the flap is situated obliquely in the dependent aspect of the renal pelvis. The UPJ is already at the dependent position. We mark the spiral flap in the dependent side. This is the marking of the spiral flap. The flap is created. The apex of the flap, the length of the apex of the flap depend on the length of the stricture of the proximal segment. The longer the segment of the proximal ureter, the farther is the apex. To preserve the vascularity, the ratio of length is to width is 3:1. Once the flap is developed, the flap, so you can see the flap is developed here. The apex of the flap is sutured to the inferior apex of the spatulated ureter. Then the similar anastomosis of anterior and posterior layer are done. The Scardino Prince vertical flap. So this is done in the box shape extrarenal pelvis. It is similar to the spiral flap, but in this the flap is more horizontal. Similar to the apex will depend on the length of the stricture here. The flap is formed in two incisions converging from the base up to the apex of either anterior or posterior of the pelvis. So we can take the flap from the anterior or posterior side, mostly from the anterior aspect. So we have marked the incision side. This incision is carried along the lateral border, and the flap is with the inferior part of the flap is sutured to the inferior apex of the cut end of the ureter, and the DJ stent is placed. Ureterocalicostomy is done in case of extensive scarring, horseshoe kidney, long segment stricture with a small intrarenal pelvis. So as we can see, there is a lot of scarring here. So inferior the lower calyx is ascect, the inferior aspect of the kidney is dissected out, the ureter is spatulated, the first suture is taken from the lateral edge of the ureter, and then a second suture is from the medial end of the ureter. All the suture are taken first, then they are tied for better anastomosis, then over a stent. Then the capsule is closed, leaving the anastomotic site open. The capsule is not closed at the anastomotic site because it may cause narrowing. Causes of failed treatment can be because of poor surgical technique, irreparable pelvic calyceal system, or PUJ ischemia causing to restenosis. There can be a anastomotic leak leading to urinoma, which may lead to inflammation and fibrosis. There may be a missed crossing vessels. The incidence of crossing vessels is around 6 to 2%. There can be a ureteric stent malfunction or any cause leading to inflammation like diabetes. Post-treatment failures mostly present within first 2 years of the procedure. Indication for placing a nephrostomy in case of a PUJ surgery can be if there is a tension, anastomosis is in tension, or if there is an active inflammation or infection, if it is a redo surgery or it is a solitary kidney. So these are the different modalities. The success rate of open surgery is about 95%. The success rate of laparoscopic surgery is about 85 to 90%. In case of endourological procedure, the success rate in experienced hands is around 86 to 90%. In case of aberrant vessel, it can be reduced to around 42%. There are salvage if there is a recurrence. In case after a endourological procedure, it is better preferred to do a laparoscopic or an open repair, which is having a result or success rate of about 80 to 85%. If there is a failure in case of an open or a laparoscopic approach, then an endosurgical procedure can also be opted. For the follow-up, the Foley's catheter is usually removed after 24 to 36 hours. Drain is usually removed when the output is less than 30 ml. After 24 hours, the output is 30 ml. The DJ stent is usually placed around 4 to 6 weeks. The DJ stent is removed after usually 6 weeks. If nephrostomy is performed, then we do a nephrostogram after 7 to 10 days to see if there is a leak. Before removing the nephrostomy, we can clamp the nephrostomy and see if there is a pain. If the patient is having no pain, then nephrostomy can be removed. Later, the DJ stent can be removed after 6 weeks. Thank you.
Yeah, Paras, it was a very nice presentation and very elaborative. Students, do you have any question? Anyone has not understood? We have got Dr. Maheshwari, Dr. Gite, Dr. G.R. Sharma to help you out to understand any procedure. This will go on the net. No? It will be on the YouTube. So you can see it again. GRS, will you like to add something to this?
Yes, sir.
Different?
Good evening, sir. A few things. It was a good presentation. I would come to few of the aspects which are more of a practical importance when you are doing a pyeloplasty. Now, as he has mentioned, by and large, most of the times a dismembered pyeloplasty is good enough. Now, very often the dilemma exists whether you should do a reductive pyeloplasty or just excise the narrowed segment and make an anastomosis. My philosophy is that if it's a markedly dilated pelvis, it is better to do a reductive pyeloplasty. Though if you look at the literature, they say there is not much of a difference between the two. But I personally feel that if the pelvis is much dilated, trim it off as much as is possible, make a dependent anastomosis. Now, another question that often creeps up is, should RGP done in all cases? Now, again, it is a matter of personal preference. My policy is that in pediatric cases, I never do an RGP. I do not remember doing an RGP in last decade or so in a pediatric age group. But in an adult, I always do a RGP. Now, it's a matter of personal preference. If you are very sure with the sonologist that the sonography has proved beyond doubt that it's a pakka PUJ obstruction, then a sonography and a rhinogram are good enough to go ahead with the surgical intervention. However, as a routine, I have done RGP in adults. Even if you do in a pediatric age group, nothing wrong. Only two practical aspects that I would like to emphasize. Number one, if you have done an RGP, put in a stent at the same time. Once you have fiddled the uretrovesical junction, subsequently it is often possible that if you try to put an antegrade DJ, it may not go. And then you are in a big soup. Whenever you have done any manipulation, which may be as simple as putting a 3 or 5 French ureteric catheter across the uretrovesical junction, subsequently put something across it. Otherwise, the chances of having a draining urine for a very long period is very much possible. Second is that when we do an RGP, we often try to fill the pelvis quite a lot. And especially in cases where there is an accessory vessel, it is often possible that the kink becomes so bad that your guide wire also does not go across the PUJ. So if you know from ultrasound that there is good amount of hydronephrosis and your RGP shows that hydronephrosis, there is no point in filling the pelvis extensively. Third, as regards putting an antegrade DJ in a child, I would say use a 3 French DJ, avoid using a 5 French DJ. I, by and large, unless the system is showing some evidence of infection, there is marked edema at around the PUJ, or it is a solitary kidney, I usually never put a DJ in a pediatric pyeloplasty. If I have done 100 pyeloplasties, I must have put DJ hardly once or twice. In an adult, it's always better because we don't know how the pyeloplasty works and it's easier to take it out also in an adult as compared to a child. Now, another question which was asked was what should be removed first, and also Brijesh in his presentation mentioned that when the output has dropped down to 30 ml, you remove it out. I think that's good as far as an adult is concerned, may not be true in a pediatric age group. Because if you are doing a pyeloplasty with a function which is 12 to 15%, and if it is showing 30 ml of drain, that is still a significant drain. And remember one thing, that when you are seeing the drain in the urine bag, and there is a continuous column of urine in the pipe that is from the drain till the urine bag, that is also full. So that pipe itself, the tube itself contains at least 25 ml of urine. What should be removed first? I would say remove the Foley first. If there is a stent in place, very often there would be some reflux, and despite the reflux, if there is no drain, then it is after 24 hours prudent to remove the drain. If you have not kept a DJ, then there is no need of even putting in a periurethral catheter, only a drain is good enough. Nephrostomy again is indicated only if it's a very difficult pyeloplasty or associated with infection, otherwise it is not needed. Now, the second point, which an important point which Brijesh highlighted was the success rate of different pyeloplasty and how would you conduct a follow-up. Gaurang sir, can I take 5 minutes to mention few things about follow-up in pyeloplasty?
Of course, of course.
Yeah.
This is mainly for you, for the students and for us to learn.
Yeah.
Why 5 minutes? You take little more.
Yes, I don't have a presentation ready with me, but there are a couple of things which I will like to highlight. One important aspect is that how do you diagnose a PUJ, and I will come to that after this particular case is presented. But as Brijesh has talked about the surgical aspects, I would mention about what would be the follow-up in pyeloplasty. Now, the commonest thing that is done now, whether you have put in a DJ or not put in a DJ, if you have put in a DJ, it is after 2 months. If you have not put in a DJ, again, it is after 2 to 3 months. The commonest modality which is used is sonography. And the sonography in the initial post-op period shows a reduction in hydronephrosis. The AP diameter of the renal pelvis comes down. And then you often advise a renogram. Now, there are various ways in which people have advised. You go by the standard description in most of the textbooks. They say sonography at 2 to 3 months and a renogram again at after the sonography is done. Some people do it at 6 months. My philosophy is I do a sonography and measure the AP diameter in supine and prone position. If it is showing a marked decrease in the AP diameter in prone position by about more than 10%, the follow-up is with sonography. But I do ask the patient's relatives to get a renogram done at the earliest after 3 months. Now, once the renogram is done, this is where the problem starts. That is the first area where the problem starts. In many of the cases, the function may not show marked improvement. Secondly, if you look at the drainage curves, they are not much different. And the third biggest issue that comes is when you look at the T-half values. I can assure you that out of the 100 pyeloplasties that are done, more than 90% of them will show a T-half more than 20 minutes in majority of the cases. And if that is so, then you again have a scenario where somebody may report it as saying, ki, okay, this is a failed pyeloplasty because the T-half is more than 20 minutes. So the marker that the pyeloplasty is a successful pyeloplasty is number one, there is improvement in the differential renal function, at least by 5%. And importantly, there is no decrease in the differential renal function. Second, whether the cortical transit time has improved. And the third, what Dr. Parag has told in the last meeting, NORA. If you start looking at NORA, you will find that in majority of the cases, the NORA improves quite a lot as compared to the T-half values. Now, consider the scenario that the initial function was about, say, 30% and you have done a good pyeloplasty. And subsequently, after 3 months, the sonography shows mild hydronephrosis. The AP diameter, which was initially 25 millimeter, has dropped down to 15 millimeter. And the renogram has jumped up from 30% to 35%. We are happy. Now, this particular patient, after a year or so, undergoes sonography for some non-specific pain in abdomen. And more often than not, the sonologist will report it as moderate to gross hydronephrosis suggestive of PUJ obstruction. Now, this happens because this pelvis, after some period of time, stretches and the AP diameter, which was 15 millimeter in the post-op period, immediately again starts increasing to 20-22 millimeter later on also in many cases, not all cases, but in many cases. So you will, in your practice, it's for all the residents that as you become more senior in your practice, you will do come across a lot of cases where the patient has undergone pyeloplasty done by you. And after 5 years, 10 years, they come back saying that the sonologist has reported that it's a PUJ obstruction. So if that happens, again, have a talk with the radiologist and tell them, okay, the hydronephrosis is going to persist. And here lies in the importance of having a renogram done in the post-op period, because if you have got the renogram, which is showing good improvement, and subsequently after 5 years, if there is some doubt and you do a renogram and the function is well maintained, then you have definitely conclusively ascertained that the pyeloplasty has been a successful pyeloplasty. So this is a big area of concern. My policy is measure the AP diameter in supine and prone. If it has increased in prone position, this is worrisome for me. If it has decreased by more than 10%, then I can keep them under follow-up by using sonography. But I do insist for getting a renogram done. And then my follow-up protocol is I keep them in follow-up for at least 3 years by an yearly sonography. And at the end of 3 years, if there is no increase in hydronephrosis and the AP diameter is decreasing in prone position, I am pretty much assured that this kidney is unlikely to have any deterioration in future. Any questions from anyone, I would be happy to answer. And subsequently, after this case, I would like to show you few sonography images as well as a video of how this sonologist actually measure the AP diameter. Would that be okay, sir?
Yeah. Yeah.
Yes, sir.
Anything else you want to, Maheshwari, want to say? Dr. Gite? Before we start the case, anything want to add? Pankaj bhai?
Okay, sir. I will add some points. As far as student and exam is concerned, stent or no stent, so always stent in answering the exam. Because if you want to do stentless pyeloplasty, if you are not told to stent, I will not put the stent. Then unnecessary Viva will go here and there, then you have to defend yourself. So better answer is stent. So why stent? So it will protect common 3-4 point, protect the anastomosis. When if there usually there is inflamed mucosa, sometimes bleeding, avoid the leak. What are the side effects? Stent symptoms. And one more surgery of stent removal, which can be done under local in adults. Always stents. Where the stent, always stent should be placed in reed hoop, functioning kidney, inflamed renal pelvis intraoperatively, or hugely dilated renal pelvis. Always try to place the stent if you are not doing the Anderson reduction. Then failed pyeloplasty treatment options. Again, radiopyeloplasty, endopylotomy, and ureterocolectomy. These are the 3 options. Always, if you want to place the stent, don't place the stent antegrade. At least for initial 5-10 years, you are that much. When you are very much senior and you are confident, you can try, because we have removed n number of stent by doing ureteroscopy placed by the surgeons. Okay, and I sir told, place the stent retrogradely before the surgery, or at least place the guide wire. Then over that guide wire, you can place the stent definitely inside the bladder. So chances of placing the stent above the bladder is completely reduced. So stent is always the retrograde, either preoperatively or over the guide wire antegrade. These are the only 2 secure things. Then DTP scan. DTP scan, sir, already told you, reservoir effect, and there are false reading of obstructions. Then patient may claim कि अभी फिर ऑपरेशन लग रहा है, कोई अकदा नया देखा यूरोलॉजिस्ट तो वो बोल देगा उसको ऑब्स्ट्रक्शन हो गया है, फिर सर्जरी लगेगा. तो एंटी सर्जरी एज वेल एज पोस्ट सर्जरी better to do a renogram, because if you have not done an anti-surgery renogram, you cannot compare with if you have done only post-surgery renogram, you cannot compare with antegrade. And if you have done only a post-renogram and after 10-year renogram or 5-year renogram, now both renogram cannot be compared because you don't have any baseline function before the surgery.
मेरा खाना नहीं आया अभी तक.
And as far as follow-up is concerned, olden follow-up 6 months sonography, 1 year DTP scan, 2-year DTP scan. This is olden one. Now 3-monthly sonography, 6-month DTP scan. Follow-up can be tailored as per the requirement and as per your experience. As sir is expert.
Sir, you are muted.
कहाँ से अनम्यूट, कहाँ से म्यूट हो गया सर? कौन से स्टेज से?
Sir, Gyanendra Sharma sir, actually you have become the host.
Okay.
Because sir's signals had gone off, so can you make Gaurang Shah sir host or me host so that I can unmute the students also?
Okay.
No, 2-3 point from my side. If I have got muted throughout, only place the stent preoperatively, antegradely over the wire, or retrogradely directly stent. That is one point. Point number 2 is in exam always stented pyeloplasty. Stentless pyeloplasty can be done. Yes, it can be done. So absolute indication for stents already I have told. If I have not got muted, I am talking about the DTP scan, baseline DTP scan prior to surgery, after to surgery, and after 5 years. As sir told कि जो जहाँ कंपेयर करना है प्रीऑपरेटिव ही नहीं है तो किसी के साथ कंपेयर नहीं हो सकता है. ऑलवेज ब्लेम आ सकता है. तो प्रीऑपरेटिव करना है, पोस्ट ऑपरेटिव भी करना है. फॉलोअप के लिए वो कन्वेंशनली 3 months sonography, 6 months sonography, 1-year DTP scan, 2-year DTP scan. Now it is changed to sonography at 3 months and DTP scan at 6 months. Follow-up can be done as per the curtail or extended as per the requirement, as per the experience. आपको जैसा ठीक लगता है वैसा. लेकिन एग्जाम में ये क्लियर कट है कि 3 months सोनोग्राफी है, 6 month DTP स्कैन. एट द ओल्डन, इसके ओल्डन एग्जामिनर अगर रहा मिला, थोड़ा ओल्ड एग्जामिनर रहा तो 2 साल तक फॉलो.
Yeah. There was one question asked in the chat box if there is an associated PUJ and UVJ obstruction. Now, first thing, it's a very rare combination. Very often, pediatric urologist or those who are operating diagnose it because they are unable to pass in a from antegrade manner. That is not UVJ obstruction, it is a technical problem. But suppose you have a scenario where there is a PUJ obstruction and associated reflux or a VUJ obstruction, which is very, very rare. Associated reflux is more common, but associated UVJ obstruction, uretrovesical junction obstruction is very uncommon. So always the pyeloplasty takes precedence. The commonest question that is asked in exam is कि अगर PUJ के साथ reflux है तो क्या करोगे? So you will tackle the pyeloplasty first. Reflux can take backseat. Over a period of time, the reflux may subside, and if in case you need to do a reimplantation, it can be done at later date. Never ever say that both pyeloplasty and ureteric reimplant can be done at the same time, because if you disconnect the ureter at both the places, then you have 100% pakka ensured that the ureter will become strictured.
Now, I just want to make a small comment that we have come across cases where we do regular pyeloplasty and patient, as you said very rightly, patient comes back, still there is a persistent hydronephrosis. DTPA renal scan shows that partially obstructed or obstructed system, and everything is falling into the picture that still there is an obstruction. The best thing is, before removal of the digest stent, I do sonography, and I tell patient, if there is no pain, there is no infection, no swelling, everything is okay, then do ultrasonography after 1 month, 3 months from the same place, and I compare it with the earlier scan. And then, as you said very rightly, if GFRS is improved, patient has no pain, patient has got no swelling, no increase in hydronephrosis. So all these things are suggestive that surgery is success.
Yeah.
So this is just a practical thing, because earlier I used to get worried that why after pyeloplasty, and then I realized when I read the literature, yet even though the renogram and everything is still showing that there is obstruction, but if clinically patient is better, there is no deterioration of the function, improvement in GFR, correct, and there is no increase in hydronephrosis, then it is a successful surgery. Fine. So can we go ahead with the case
Yes,
number
sir.
3?
Yes, sir. After the case, I will just make show
Yeah.
images and
Yeah.
videos. Yes, sir.
Yeah. So this is a little different, means PU junction for little elderly female. So you please take over, because this is little tricky case.
Yeah.
You, Dr. Gite, Maheshwari, Hiren, please.
This is a case of a 68-year-old female presented with a complaint of pain over the right flank for 5 months with fever with nausea and vomiting with decreased
Just
range.
1 minute. Paras, 1 minute. Who is answering today?
Sir, me, Rahul. Please make me co-host, sir.
Sir,
Hello,
myself, sir, Dr. Anand.
And myself,
Anand
Dr.
and
Rahul.
Rahul, na?
Rahul.
I'm Dr.
Sir.
Sriram, sir. I'll also be answering, sir.
Sir, Anand, sir.
Rahul. So Rahul, Anand, and
So, Sriram, sir.
Sriram.
you are joined as a Sriram only or some other name?
No, he's joined as Shriram only, sir. Shriram Sawant.
Yes.
Anyway, you continue. I will see and I will.
He is already a co-host, sir.
He is already co-host, yeah?
Yeah.
Okay, fine.
So 68-year-old female with a complaint of not by right flank pain, it was a bilateral flank pain. Right flank pain was on and off for 5 months, and the left flank pain was since 6 days. There was history of fever. There was history of nausea and vomiting. So the right side pain was dilating in nature, sudden onset, radiating to back, gradually progressing, associated with nausea, and was relieved on medication. The left side pain was about 5 days back. It was associated with fever, with nausea, with vomiting. There is no lithuria, hematuria. There is no facial puffiness, exertional breathlessness, lower limb edema. There was no bleeding disorder, anticoagulant therapy. Patient is known hypertensive, known diabetic. There is no history of any surgical intervention in past. Patient has attained his menopause at 50 years of age. There is the patient is having para 2+0. On examination, there was a right renal fullness with left renal angle tenderness present. No lump was palpable. There was no other significant finding.
Yes, so any one of them, Rahul, Anand,
Yes.
you want to ask any particular question?
Sir, I would like to know about the kind of the pain. Pain is dull aching or colic in nature on the right side pain first. And as well as, sir, left side pain, I would like to know about the duration, onset, and progression, as well as associated symptoms with the pain, and whether it is dull aching or colic in nature, which is mild, moderate, and severity of the pain, associated symptoms, relieving factor, and aggravating factor of the pain, and which side is having more severity. I would
More
like
pain.
to know.
And also, sir, non-urological causes that bowel disturbances and any colic symptoms associated to bowels. Sir. He hasn't mentioned non-urological causes of pain.
So the right-sided pain started 5 months back. It was on and off. It was dull aching, non-radiating, but it was relieved on taking medication. The left flank pain was of recent onset, about 5 days back. It was colicky in nature, sudden onset. It was associated with fever and nausea and vomiting. There was
So
no
any lower
hematuria or lituria.
any lower urinary tract symptoms associated with the pain?
No.
Yeah. So what will you do? What will you ask for?
But I would like to
Sir,
ask for a complete blood count. I would like to look at a total counts. I would like to look for a creatinine insert and electrolytes first, and a urine analysis. Because examination is also revealing tenderness on the left side. Left renal angle tenderness is there.
and bedside, OPD based ultrasonography of abdomen and pelvis.
This is urine report.
So the urine report shows about 5 to 20 RBCs per high power field, plus RWBC 75 to 80 per high power field. There is a protein present in the urine. There's bacteria is also present. The culture sensitivity shows innumerable pus cells. There was E. coli grown in the urine, which was sensitive to the drug shown. The hemoglobin was 11, the counts was 13,800, creatinine was 5.4, INR was 1.24, the potassium was 5.2, and the CRP was 55. So these are the sonography images.
What, Rahul, what important thing has not been mentioned in the lab reports?
Sir, differential count. We should know about differential count also, and
HbA1c and sugar value, sir.
Yes.
HbA1.
Yes.
Very good.
Before sonography, what is your diagnosis?
Sir, correlating the renal angle pain with pyuria with raised counts and acute history, most looks like, sir, left-sided pyelonephritis is there, and
Sir,
right side
bilateral obstructive
Bilateral
uropathy.
should be bilateral.
Bilateral
Sometimes
obstructive
bilateral.
uropathy
Yes.
may lead to the condition.
What bilateral obstruction you are expecting?
Sir,
So
it may be possible, sir, bilateral ureteric calculus.
Ureteric obstruction.
Ureteric
Secondary to
calculus may be
calculus.
present, sir.
So same
So
picture.
other differential diagnosis.
Your primary diagnosis, first diagnosis is stone disease
Yes.
Yes, sir.
with obstruction. Second, third diagnosis.
Sir,
So it could
due
be
to the
papillary necrosis also due to uncontrolled sugars. We don't know sugar status on the left side. Obstructive uropathy due to that.
Slough of
Why
papilla.
possible, but it is very rare ना bilateral renal papilla आ गया दोनों तरफ से block कर दिया पेन दोनों तरफ से है ना
bilateral obstructive uropathy
तो हो गया stone disease आगे बोलो
Pyonephrosis.
Bilateral PUJ obstruction, sir.
Okay.
Don't tell the pathology, tell the cause. Stone disease, one word.
Oh,
Pyonephrosis, obstructive uropathy are all general terms.
Bilateral PUJ obstruction, sir.
Possible. Next.
Then
Sir, bilateral
bilateral VUJ
stricture,
obstruction.
VUJ obstruction.
Why?
Second into
Some. What some?
So CS cervix could be a possibility in this age group.
mass,
Bilateral
blood
HUN
vessel
with
mass.
causing.
Possible. Next.
So VUJ.
ये सर्विक्स रह सकता है, बोल दिया,
CS
स्टोन
cervix,
बोल दिया,
sir.
पीयूजे बोल दिया, और कुछ?
It can. The last possibility, rare, sir, could be a bladder tumor which is obstructing both UOs, but there is no other history of hematuria or anything.
Bilateral renal cystic disease, sir.
Yes, cystic disease can be common.
Oh.
Cystic disease with infection.
Yes, sir.
Possible. तो अभी ये सिचुएशन, हाँ, उसके साथ में फिर obstructive uropathy secondary to 1, 2, 3, 4, 5 with left-sided pyonephrosis या pyelonephritis, जो भी हो क्लिनिकल पिक्चर है.
Yes, sir.
तो ये डायग्नोसिस क्या है बोले तो obstructive uropathy, मतलब व्हाट obstructive uropathy? ठीक है, आगे.
You said stone, bilateral or papilla, so it can be one side stone, one side infection also.
Yes.
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 Possible.
One more thing we should keep in mind is retroperitoneal fibrosis.
Yes, sir.
I really agree with you. Unless and until we keep it in mind, we don't diagnose it.
नहीं, यूजुअली प्रॉब्लम एग्जाम में वही होता है सर कि इनको डायग्नोसिस पता रहता है और फिर वो दूसरा सोचते नहीं और एग्जामिनर वो छोड़ के दूसरा ही पूछ लेता है.
No, you are right. Okay. Now sonography. Achha, one more question. Anand, what antibiotic would you like to give? Don't see the marker, no? Don't see the marker, please.
Sir, in this situation, you can go for cephalosporin.
Second generation cephalosporin, sir.
Cephalosporin.
अरे ऐसा मत बोलो.
Dr. Maheshwari and Dr. They have really given a very good talk on use of antibiotics. So can you just explain them, Maheshwari or Sharma ji?
पंकज सर.
बोलिए ज्ञानेंद्र जी, आप बोलिए.
अरे सर आपके रहते नहीं.
So basically the way to choose antibiotic would be the factors deciding will be what is your local antibiogram and renal function and hepatic function. In this patient where creatinine is raised, obviously on day 1 I would not have the urine culture report. So based on my local antibiogram, I would in this patient initially start say Magnix, cephalosporin sulbactam. And once I get the culture, so it's a broad spectrum antibiotic that I start with. And once I get the culture report, then I'll zero down based on what the culture report shows.
Now this is, I think we should consider this as a complicated urine tract infection, correct?
Yes.
So in that, it is not advisable to go. Normally, they say that the cheapest and the most sensitive, like and the lowest molecule should be used. But in this case, I think we should go for little higher molecule, which is most sensitive. Instead of oral, it is better to go for IV. Right, Dr. Maheshwari?
Yes, this patient, we are suspecting bilateral obstructive uropathy. The creatinine is raised. Patient is presented with features of sepsis, so we will need to be more aggressive.
Yeah.
Okay.
चलो आगे चलते हैं.
Okay, Paras, आगे.
So this is the sonography image which we have got. It is less clear. So I will read out the report.
Yeah, less clear is the understatement.
So the right kidney measures about 9.4 into 5.3 centimeter. There is severe hydronephrosis with ballooning of the renal pelvis. The cortical thickness in this kidney is around is 12 mm, 11 mm, and 10 mm at the upper, middle, and lower pole. The renal pelvis AP dimension is 7 centimeter. The ureter does not appear to be significantly dilated. The left kidney is also bulky and edematous with cortex prominence of the pyramids. It is about 11.2 into 5 centimeter. There is no perinephric fluid, focal abscess, or evidence of hydronephrosis.
Yeah.
Can you go back to the previous image? The
There
report
is
and the
nothing
images
visible
don't
here.
match. Huh?
Absolutely don't match.
7 centimeter AP diameter mentioned in the right kidney. I don't know which is the right kidney. I think on the left hand side, ऊपर से जो third image है, नीचे वाली, that could be the left kidney, but otherwise 7 centimeter AP diameter looks not possible with this
Anyway,
image.
let's leave it at poor
Leave it.
poor images.
Yes.
And go by the city Sono report.
Yes. What next?
Sir, I would like to admit this patient and start appropriate IV antibiotics and renoprotective medications I will start, and then, sir, I will assess
Here,
and monitor the patient.
What renoprotective medication you will start?
Sir, soda bicarb, alpha calcidol, Shelcal.
But I don't think soda bicarb is renoprotective.
Sir,
Rahul,
yes, sir.
better ways I will take nephrology opinion or advice. ऐसा
Yes.
बोल के
Yes,
छूट
sir.
ऐसा बोल के छूट जाना.
Okay, sir. Yes, sir. Sir, I would like to
So you
admit this
invented
patient.
this question by using the word nephroprotective medications.
Yes.
Sir, N-acetylcysteine is one of the renoprotective.
Sir, that is used in specific indications.
Sir.
It is not used in every patient who is having raised creatinine.
Yes, sir.
अगर वैसा रहता तो हर नेफ्रोलॉजिस्ट का पहला ड्रग यही लिखे थे. You will rarely see nephrologist writing this drug. Okay, so as Dr. Gite sir has said, you will take a nephrology opinion. As a urologist, तुम्हारा plan क्या रहेगा?
Sir,
CV antibiotics,
see,
sir.
sir.
She needs a catheter, sir.
After
Catheterization.
Catheterization.
Sir is asking plan. तो तुमने एडमिट कर दिया, सलाइन लगा दिया, भाई ब्लैडर फुल है तो कैथेटर भी कर दिया. प्लान मतलब वो प्लान नहीं, आगे का प्लान बोलो. इसका डायग्नोसिस हो गया क्या?
No, sir.
तो फिर क्या कैसे प्लान बताएंगे?
Sir,
प्राइमरी बेसिक रिक्वायर्ड थिंग जो है एज एडमिशन, एंटीबायोटिक, आईवी फ्लूइड जो भी था वो आपने बोल दिया, इन्वेस्टिगेशन भी कर दिया. अभी ये दीज आर द ऑल रिक्वायर्ड बेसिक इन्वेस्टिगेशन है. डायग्नोस्टिक इन्वेस्टिगेशन क्या हो गया? एक सोनोग्राफी हो गया.
Plain CTK.
Non-contrast CT scan of abdomen and pelvis. After that, I would like to plan my treatment.
चलो है क्या नॉन कॉन्ट्रास्ट सिटी?
Paras, show the CT scan. Yeah.
Sriram.
Yes, sir. On the CT scan, sir, on the right side, the kidney, there is large hydronephrosis. There is no discernible cortex also
What
visible,
is
sir, on
small
the right.
hydronephrosis?
Some hydronephrosis is visible, sir.
See, देख श्रीराम, यानी we need to be, क्या होता है when you read a CT scan and especially with the stress of the exam, we forget the correct use of words. Large hydronephrosis, small hydronephrosis नहीं होता. It is mild, moderate, severe.
Yes, sir.
फिर वो कोई तो जिस एग्जामिनर का मूड खराब है फिर वो चालू हो जाता है. लार्ज हाइड्रोनेफ्रोसिस का डेफिनेशन क्या है, स्मॉल का क्या रहेगा, फिर ये सब तकलीफ के काम हो जाते हैं. सो बी वेरी स्पेसिफिक अबाउट द चॉइस ऑफ योर वर्ड्स व्हेन यू आर डिस्क्राइबिंग एनीथिंग और सेइंग एनीथिंग. Describe it, na?
Yes, sir.
Describe the CT scan.
Sir, both the kidneys are normal in location. On the right side, there is hydronephrosis evident. There is no visible cortex or parenchyma can't be made out. It's a large hydronephrosis. On the left side, the kidney appears slightly bulky with perinephric fat stranding.
Can you show the ultrasound report again, please? No, not the image report. See, you have mentioned there is no parenchyma seen. What is mentioned on sonography is the cortical thickness of 12 mm, 11 mm and 10 mm.
Yes, sir.
चलो CT दिखा दो वापस.
And you can surely see the parenchyma, though it is
Definitely it is
diffused,
seen.
but there is definitely parenchyma seen.
Shriram, I think a better way to describe it would be normal location बता दिया है. There is a markedly dilated renal pelvis which is seen with the PUJ extending right till the midline. There is definitely some parenchymal thinning which is seen, but the parenchyma is seen. And on the left side, you are seeing some dilatation of the pelvic calyceal system as well as a hydroureter is seen in the reconstructed images.
Yes, sir.
अब क्या करोगे?
Taking into account the raised counts and creatinine, we have to decompress both the systems, sir. I'd like to proceed with degestenting on both sides. To decompress our systems and stabilize
आप
it.
क्या करोगे?
No, what is your problem on the left side? What do you suspect on the left side?
Left side, some amount of infection is there. So pyelonephritis may be there on the left side, suspecting that.
So
Left side
why
was
is then
acute
the
history.
ureter dilated?
So there may be a sloughed off papilla in the ureter on the left side. Because there is no
So
evident
what do you
stone
think is
there.
the cause of his raised creatinine?
Sir, right side non-functioning kidney with left side
No,
obstructive.
don't use the word non-functioning. You say poorly functioning kidney.
Poorly functioning kidney.
We have not documented non-functioning yet. So probably it was to begin with, it was a solitary functioning kidney with right side poorly functioning kidney, and that has got blocked with the papilla. Okay. Is there any tenderness on the right side or any symptoms on the right side?
No, sir. On right side only, on and off.
Then what is the hurry to put a tube or nephrostomy on the right side?
So she's having bilateral pains.
She's having bilateral pain. Okay.
Yeah.
Fair. Then it's okay. So my diagnosis probably is right PU junction obstruction with a poorly functioning kidney, left better functioning kidney, which has got blocked by some acute pathology, most likely a papillary necrosis. So I would put, if there are symptoms on right side, only then I'll place a stent. Otherwise, I would just place a stent on the left side at this time.
Right.
आपको क्या लगता है गणेश?
So,
Yeah.
so Anand, I will just ask you, Anand, what is
Yes, sir.
your say? Whether you like to just say whether you like to do GTP and renal scan before doing any procedure, yes or no?
Yes, sir.
Okay. What about Srinivas?
So now, acute, first we have to stabilize the condition of the patient. So there's acute infection. After stabilization, we can plan if needed.
So how much
Srinivas.
time it will
Study.
take to do DTP? You had done the CT scan. How much time the DTP renal scan will take? Another
Sriram,
45 minutes.
Yes, sir.
sir,
45 minutes to 1 hour. Sir.
So whether I'm just asking you, I'm not saying that you must do it.
Yes, sir.
This is just a question. So whether you will do it or you will just proceed with the procedure.
No, sir, I would like to do it, sir, after the acute condition is stabilized.
And what about Rahul?
What do you mean
Rahul,
the
Sriram,
acute condition is stabilized?
Sir.
Means after antibiotics or after stenting?
After
Sir,
stenting, sir, a condition will be stabilized after a process stenting. After the condition stabilizes, then we can
So
plan,
you
sir,
see, at
for
this
the
time
right
his
side.
creatinine is more than 5.
Yes, sir.
At
so
this
why you
time,
want
the
to do
creatinine
DTP?
is more than 5. Patient is in infection. There is no place for doing a nuclear scan at this time.
Yes, sir.
Doing a DTP scan with serum creatinine 5. Is it okay?
No, sir.
No,
no,
sir.
sir. No, sir.
Right now, what is your priority?
To decompress the
Stabilize.
system
Decompress the left
and-
side.
Decompress on the patient.
Decompress the system either
and
unilaterally or
stabilize the
bilaterally,
bilateral.
as per the symptomatology. Definitely on left side.
Yes, sir.
Barabar hai?
Yes,
So
sir.
Yes, sir.
what decompression you want to do?
DJ stenting, sir. On the left
DJ
side.
stenting, sir.
Digestating bilaterally or unilaterally?
Yes, sir.
Bilaterally.
Bilaterally.
Before digestant, you want to search some right side, you know there is a PUJ. Left side, you don't know. There can it be just a passed out stone?
That is a possibility, sir.
Possibility.
So CT scan doesn't give any reason to why it is dilated column of ureter from right up to VJ, from PUJ. उसको सर्च करेंगे कि सिर्फ स्टेन डाल के चले आएगी?
So right now we'll put a stent, sir, because it's an acute condition. Later needed, we can check, sir.
पंकज सर, सर्च करना नहीं करना?
No, the question that sir is trying to ask is, will you do a retrograde pyelogram at the time of stenting?
Yes.
Exactly. Search matlab not by doing ureteroscopy.
Will RGP give you an answer?
No, sir. It may not give us an answer because we may risk disturbing the already infected system is there on the left side. We're suspecting that. So in that system, injecting contrast would
How
be
much
more
is the
risky.
hydronephrosis on left side?
So not much, sir. Minimal. Compared to the right, it is left, sir. Less, sir.
Okay, you can defend like that, but what is wrong in doing some one RGP and visualizing ureter? Because you can just at least know the site of block. It has a filling defect.
Yes, sir.
Stone रहा तो भी दिखेगा, दूसरा stone नहीं भी रहा
You
तो
can
दिखेगा.
take precautions while sorry, आप बोलिए.
नहीं सर, नहीं सर,
You
बोलो. हाँ.
can take precautions while doing RGP. You will not be very forceful. You will use a dilute low volume contrast, gradually fill the
Yes, sir.
system. There are advantages of doing RGP because you see in an inflamed system, there is a very high risk that even your glide wire can go out of the pelvic system. So I would definitely want to identify the PCS before I place my stent. So it will give me
Yes,
a
sir.
rough idea of is, and it will help me place the stent properly. Obviously, I'm not going to distend the system with 20 cc contrast. It's
Yes,
just maybe with this CT scan that you have seen, probably the volume of PCS will be 5 to 6. That is what I'll put at a very, very without any say pressure on my syringe when I'm installing it. So a
yes, sir.
gradual, slow installation of contrast may help you identify the cause, but will definitely help you place the stent properly. In inflamed system, remember the chance of guide wire going out may be as high as 20%. It is very common. So always put a contrast, dilute, low pressure contrast when you are placing a stent.
Sir, in this case, the area of target is huge. So
Yes.
amount required to visualize the ureter is very less.
Very less, absolutely.
2-4 सीसी भी डाल दिया और ऊपर चला गया तो सिस्टम भी विजुअलाइज होंगे और तुमको ब्लॉक भी दिखेगा. हाँ, suppose if on right side, then the hugely dilated system, large amount of contrast is required, already infected. यहाँ लेफ्ट साइड को तो डाल के देखने में कोई हर्ज नहीं.
Yes.
Fine. Okay. So now next, what you want to do? Paras, just show them what we did.
The CT report was suggestive of gross dilatation of the renal pelvis and the calyces with associated thinning of the overlying cortex and abrupt narrowing at the PUJ. The right ureter appears normal in pose. These features are suggestive of right PUJ obstruction. There is no evidence of calculi or perinephric fat standing. On the left kidney appears to be bulky, around 11.5 into 7.1 into 4 centimeter. There is a wedge-shaped hypodensity lesion seen in the upper interpolar and lower poles. There is mild perinephric fat stranding with thickening of the anterior and posterior renal fascia, feature suggestive of pyelonephritis.
Fine.
So we admitted the patient, we started the antibiotic, and we did a bilateral DJ stenting. After bilateral DJ stenting, after 4 days, the patient was stabilized. The creatinine came down to 1.8, and the count was reduced to around 8,000.
So show them the DTP renal scan at that time.
Cannot make out anything.
Difficult. Show the another film. Next one. So effectively, the right kidney was not showing any function with the reduced creatinine. So we kept the stent and repeated a DTP renal scan with the infection, everything under control. I think, Paras, after how many days?
So after around 2 months, sir.
So what was that? Do you have that?
Sir, I don't have the report, but after 2 months, after removal of the DJ stand, we repeated the DTPA scan.
No. Before that, we repeated, and it was 22 to 24%, the right side.
Yes.
And the GFR was also, I think, quite okay. So now the question is what to do. So I will ask Anand. All three of you say what you want to do. Anand, what you want to do, Srinivas and Rahul. So Anand, you start.
Sir, as the right side kidney doesn't show any function, sir, and left side kidney 100% function, and it is showing PUJ
No,
obstruction.
after 2 months, there is a improvement in the right side, and it is showing 22 or 23% of function
Okay, sir.
percentage.
Okay, sir. Yes, sir. After 2 months, the right side function is 20%, and left is definitely the reduction in the function secondary to the PUJ, sir. I will plan this case for. I will discuss all the possible option with the patient, sir, for left pyeloplasty, sir. First,
Left or right?
right, sir. Right. Sorry.
Srinivas, what you want to do?
The function is decreased about 22% is still okay. Left side is compensated hypertrophy.
Hypertrophy नहीं है श्रीराम. It is not a
ठीक है.
hypertrophic kidney. Gite sir,
Don't
आप
worry, even
guide
if
कीजिए.
Would keep the patient. So we'd keep the patient on follow-up, but I would counsel them that some point if another bout of occurs and the right side kidney is not functioning well, but it is not coming into criteria for nephrectomy yet, but she may
no,
require.
I
on the
am
right side.
asking you directly 3 questions. She has got bilateral digestion.
Yes, sir.
Whether you like to, number 1, you want to remove both the digestion and want to see. Number 2, you want to do right-sided nephrectomy and removal of the digestion on the left side. Number 3, you want to do pyeloplasty on the right side and remove the left-sided digestion. And number 4, you want to just change the digestion.
Sir, I would remove both the stents, sir, first, and repeat the DTPA scan after 4 weeks. And at this, as you said, the right side function is 20%, sir. I will post her for after discussing with the patient. I will post her for pyeloplasty.
Listen,
20,
why you have
20.
why you have placed the stent?
So for stabilization.
Then why you want to remove for stabilization of what?
The creatinine.
Why it is raised?
Second, it is an obstruction.
Then have you done some treatment for that obstruction?
Sir, after 4 weeks, sir.
No, why
Sir,
before doing the treatment, why you want to remove the stent?
What is your logic of removing stent?
दिल में आया ऐसा कुछ
How
भी
will
कैसे क्या
stent
बोल
removal
सकते हो?
benefit you?
If the function as per the DTP scan done second time, if function is raised and if GFR is 22 on right side, what you want to do on right side?
Why are you hesitating in saying pyeloplasty? Means what is the problem against pyeloplasty?
Yes, sir.
दूसरा कोई ऑप्शन है क्या?
No, sir.
डायलेटेड बैगी पेल्विस है, फंक्शन बढ़ गया है, स्टेंट के बाद में फंक्शन इंप्रूव हो गया है, तो अब स्टेंट निकालने के पहले उसका कुछ तो क्रियाक्रम करना पड़ेगा ना?
Yes, pyeloplasty. Pyeloplasty, right side.
So Anand is saying pyeloplasty. Srinivas, what do you want to do?
Pyeloplasty, sir, on the right side.
Okay.
But why
Rahul,
were
what you
you
want to do?
hesitating in deciding
Sir,
pyeloplasty? Means what was against pyeloplasty in your mind?
On right side, pyeloplasty with stent, and left side I would like to keep digesting for more 3 months.
Why?
Change the digestion. Why?
Why you want to keep digestion for 3 months? That in spite of that, tell I will do left side cystoscopy, stent removal cystoscopy RGP. Rule out any their obstruction is there still or not. If it is ruled out, I will remove the stent. On right side, I will do a pyeloplasty and place the stent if required second time. That's all, na?
Yes.
Yes.
You see, ideally we should be managing the better functioning kidney first. Okay. Your left kidney is the better functioning kidney. So definitely your plan should be a cystoscopy, left stent removal, RGP. If you see any papilla or filling defect, then a ureteroscopy to remove those papilla or filling defect. If you remove a papilla, replace a stent for some time. If there is no papilla found, remove the stent and wait. Left side treatment is over. Right side, there is no other option but to do pyeloplasty. Don't do the experiments of removal of stent. Removal of stent, unless you take care of stent, your patient will again land into infection. You see, there has been a foreign body, patient is diabetic, patient is old. If you remove the stent in such situation, leaving an obstructed system, they will land into again infection and pyelonephrosis. So there is no question of removal of stent. And I think this is how you would manage. And I'm sure this is what you do in your hospitals regularly.
Okay.
Please try to say only what you do in your place.
Correct. Now, Rahul, Srinivas, and Anand. One more question. Now, there is still persistent pus cells seen in urine. You will do directly pyeloplasty, or you want to now you're suspecting there is an infected system on the right side. So you want to do PCN and then go ahead, or you will directly do, or you want to do nephrectomy. Three options. If there is a persistent large amount of infection, it is infected urine, you want to do pyeloplasty, you want to do PCN, or you want to do nephrectomy. Anand,
Sir,
you start.
I would like to do.
Or you want to give a better antibiotic, still wait and go ahead.
Yes, I will upgrade the antibiotics first and see how it is respond.
Okay. Suppose it is not responding now. So you have got a three options. Don't worry, just answer. Or even many of us doesn't know what to do. Just tell us.
Sir, I would like to do right PCN, and I would like to send PCN fluid for urine culture sensitivity and start antibiotic according to that. And after once infection or it's sterile, urine sterile, then I would like to plan for the pyeloplasty.
Okay, Srinivas, what you want to do?
Sir, same sir. I would like to decompress the right system, put a PCN, start her on IV antibiotics, and then plan for the pyeloplasty when the, culture is no growth, so culture is sterile.
After placing the digest stent, how many days you will wait? When you will going to decide to place the patient? On what clinical and radiological investigation will help in deciding the patient after doing the DJ?
Ultrasonography, I would like to do ultrasonography. If there is persistent hydronephrosis and pyonephrosis is present, then I would like to go for the PCN placement, sir.
So ultrasonography suggests you have hydronephrosis with internal leakage. Urine routine shows persistent pus cell. Patient is symptomatic in spite of stent. Then it means your stent is not working. Then only there is a role of patient.
Yes.
Then here in this space, sir, Boli.
You see, don't give too much significance to pyuria. With the stents in place, urine will always show WBC. Sometimes I would go to the extent of saying don't even give significance to urine culture report. A lot of time culture tests are not very well done. I would take this decision more clinically. Yes, if the patient is running fever, patient has significant renal tenderness, definitely a place for PCN. But unless fever, renal tenderness, just urine routine showing WBCs or bacteria, don't chase it at all. That is normal with stent in place. One treatment in between, say, stent and PCN could be to place just a Foley catheter. If you keep the bladder empty, with the stent, the systems tend to drain better. So this patient is very unlikely to present with sepsis after the stents have been placed. Stent, do not look for urine routine. Never do a urine routine with the stents in place. Only if symptomatic, do a urine culture and consider pyeloplasty once the creatinine is stabilized. Do you agree, Dr. Gite?
Yes, sir. 100%.
So the only indications of nephrostomy will be persistent fever and renal tenderness. Otherwise, I would not go for PCN at all in this patient.
Yes.
You see,
Yes,
based
here
on
is the
based on the chat, I would want to make few comments. There are few things we need to understand in this patient. The first DTPA was done when the creatinine was 5 and patient was in sepsis. So let's not give any significance to the zero function that was seen on that DTPA. Probably that time the DTPA may not have given us any information. Second, you see, somebody has written CT scan with bilateral digestant and right PCN. Do not advise CT scan and treatment simultaneously. First see the CT scan and then decide the treatment. Sometimes your treatment will change based on what you see in the CT scan. Between the nephrostomy and digestant, unless you have very thick pus or a very, very poorly functioning kidney where you may contemplate nephrectomy, only then I would put a nephrostomy tube. Otherwise, most patients I would put a digestant. Why nephrostomy tube? Because through nephrostomy tube, I will be able to keep a tab of how much output comes from that kidney, and the daily output from that kidney will help me decide whether it's a salvageable kidney or not. Otherwise, most patients with infection, digestant works as good as PCN. So just because it is severely hydronephrotic, if not severely, paper-thin cortex, severe thick pus, definitely a nephrostomy. Otherwise, most patients go for a digestant. Now, Ashlesh has written there is no hydronephrosis, then why try to see for obstruction? You see, there is mild hydronephrosis, Ashlesh, here. If there was no hydronephrosis, why would there be mild fillness of PCS? Why would the creatinine go up? Why would it stabilize after you place a stent? So this is a classical picture of papillary necrosis, which presents like this, and digestant in such situations is absolutely essential. Brijesh has asked, can DTPA be done with digestant or PCN in situ? You see, in DTPA renogram, to look for function, you look within first 2 minutes. You do not look in the later images for the function of the kidney. And the first 2 minutes, the vascular phase is not hampered by stent or PCN. So definitely DTPA can be done at that time. Acute pyelonephritis, there is a place for digestant. If there is no hydronephrosis, you start with antibiotics, observe. If over 48 hours patients don't improve, there is ample literature to say that a stent can be placed even if there is no hydronephrosis. If there is hydronephrosis, definitely you need to place a stent.
Yeah, one more point is about the DTPA renal scan. Just understand, DTPA renal scan is not only for the obstruction. So if you want to see the obstruction, then with the digestant you will not do it. But if you want to see the relative function, yes, with the digestant you can do DTPA renal scan. Now this is a RGP we had done while putting the digest.
Okay.
Unfortunately, patient was again admitted. This is on the right side. As you can see, there was little, it was very, very bad picture or stenosis, fibrosis. It was not like a congenital PU junction obstruction. And there was some extravasation at PU junction also. But then we could successfully put it. The first DTPA renal scan was done after 5 days when the creatinine had come down, but probably the kidney might not have recovered, in these 5 days. So that is why it was showing zero function. Unfortunately, patient got admitted under someone else, and then decided to remove the double J stent. After that, we don't have any follow-up. Yeah, Sharmaji, you want to know your final comments overall?
Sir, overall, I
Not
think
only this case,
I agree
your
with.
total comment.
I would agree with Pankaj and Gite sir ki right-sided pyeloplasty and at the same time evaluate the left side by an RGP or a ureterorhinoscope. If there is a slough papilla, remove it. Pyeloplasty would be a straightforward procedure in this case. Sir, before we end, मैं एक अल्ट्रासाउंड ये दिखा देता हूँ how AP diameter is measured. And sir, if you permit, I would ask my wife to give a commentary because she does the ultrasound. I don't do it.
Beautiful. These small things are our pulse of our clinic. When someone who is master in that particular field comes and talks for even 10 minutes, you know, it helps our students and also to us to learn, you know,
Sir,
better things.
Sir, I'll just. Just a second, sir. I will show another video. Sir, are you able to see this?
No, we are not able to see.
No, sir.
Okay. Sir, is the screen visible now?
Yes.
Yeah, now it is visible.
Yes, sir. Sir.
Ideally, it should be an empty bladder, but 5 to 10 ml. We turn the patient to the side, which is so now this is a kidney, which is in longitudinal as well as in transverse position. So when you see a launched kidney, you will see an elongated renal structure, and here this is the transverse view of the kidney. All measurements should be taken in transverse view. So this is the intrarenal part of the dilated pelvis, and this is showing approximately 23 mm here.
Sir, a comment which is for the residents that sometimes it is asked that how will you measure the AP diameter? It is measured in the axial image within the confines of the renal parenchyma. And there is a study by Nguyen. I don't know how it is pronounced. The spelling is Nguyen. He was the head of the multidisciplinary committee which came up with the urinary tract dilatation UTD classification. And he has written a paper where he says that the AP diameter should be measured within the confines of the renal parenchyma, because if you measure the extrarenal pelvis, it often leads to erroneous conclusion. And this is what is exactly depicted here.
So now that you have seen, now I'm turning the patient. Pura palta suture. So you have a transverse view of the kidney and the intrarenal part seen here. Now I'm taking the measurement at the brim. So this is around 16 mm. You see that there is a drop of the diameter from 23 mm to 16 mm when bone position.
Sir, this is a patient who was diagnosed as having bilateral PUJ obstruction and was advised bilateral pyeloplasty at the age of 3 months. He needed only one-sided pyeloplasty. The other side, unfortunately, what happens now, is about 7 years old, 6 years old. Whenever he has pain in abdomen or any non-specific symptom, he goes to a sonologist. They do a sonography. They say there is a PUJ obstruction, and he comes running to me, "Ki sir, abhi bhi sujan hai." So that kidney is functioning well. So this is one example of how if you have a good images and it shows a drop in the AP diameter in prone position, this suggests that there is a good drainage. There is another video I can show. Second ये. Sir, एक second. Yeah, is it seen, sir?
Yeah,
Yes.
yeah, we can see.
Yes.
So now when the calyces are also dilated along with the pelvis, so there's a now what we follow is take measurements of the calyces as well. So now here is one example where we are taking the upper pole calyx and the lower pole calyx, and they are measured here in the supine position. Then the patient is turned prone, and the same calyces and the pelvis as well are measured again. So when you do measurements for the calyces, it has to be in the longitudinal plane, and the axial plane is used when you are doing the pelvic, the diameter for the pelvis. So this is when the patient will be turned prone. Again, you are measuring these two calyces and the renal pelvis here. So the important feedback here is that you have to measure it in the confines of the renal parenchyma, number one. Number two, be sure that you are measuring at the same place. Like suppose it's in the supine position and you are measuring it here somewhere. And again, when it becomes prone, you are measuring somewhere on the top part, on the peripheral part. Then it doesn't work. You have to be pretty sure what area of the calyx are you measuring. So even if whatever calyx you choose is okay, you can, but preferably I use the lower pole calyces, and because it's easy to identify them. Also, when I'm one very important thing that I've seen about the pelvis is that the pelvis takes a rounded shape when it is dilated, and when we are turning, when we are taking a transverse view. So when it is rounded, what happens? It becomes a circle. So anywhere you take a diameter of this circle will be the same. Okay, so now whether you are measuring it from one end to the other, or so that's why in my previous days when we were not using this system of calculating it in the confines of the renal parenchyma, I was trying to get a rounded picture of the renal pelvis, and when it was absolutely visibly round, that time I would take the diameter, and that would give me something like a diameter of a circle, which I would take both in supine and prone, and a decrease of 10% would tell me that okay, I mean, I would just mention it that there is a decrease. So I only mention the diameters, and the rest of the interpretations are done by him. So it's okay.
Yes, sir. Sir, any questions pertaining to this?
No, you have, she has explained this very nicely, and now I request everyone that whenever they are doing, they should go to ultrasonography and see themselves. I think that is the most ideal thing. And for that matter, I think even CT scan, MRI, it is always better to go and discuss.
So for sonography, I feel the same sonologist and have a good conversation or a discussion with him ki what we expect from the sonologist, because they are trained to do sonography in a particular way in their residency. Our thinking is different. So unless we convey to them what we want, most of the radiologists will never give us the report that we are interested in.
I agree. Unless and until we tell them what we are expecting.
Yeah.
I think this is a good demonstration how to look into the ultrasonography, and thank you very much for that. If there is no further questions, then we can stop our meeting over here. I think we have done good for Q junction obstruction. If anything is left, just let us know. VRS.
Sir, I think we have covered most of the things.
Covered everything. Yes, yes. Fine. Okay. Anything new, you can put it on a group.
Sure, sir.
Only one small thing is that Tanvi is going to ask all of you because of some circumstances. That is, one is that in Indian School of Urology as well as AUA has got some teaching program going on Tuesday. I requested them, but they said it is not possible to change it for this year. So whether we should continue on Tuesday or we should do it on Thursday. Then we will circulate the form. Please fill up and so that we can decide whether we should do it on Tuesday only or we should take another day, that is Thursday. Okay, fine. GRS, every time I tell you GRS, I am happy.
Yeah.
Because I'm telling myself also.
Yeah.
Okay. Okay.
Right, sir.
Thank you. Thank you very much.
So much, sir.
For your input.
Good night.
Thank you.
Good night.
Yes.
Good night, sir.
Good night.
Good night.
Yes.